Good afternoon. Thanks for joining us for today's webinar. It's the second of 3 webinars in the Genomics in Practice webinar series. And in today's webinar, presented by Dr. William Audeh and Dr. Jaime Alberty, we'll review the latest MammaPrint and BluePrint data, clinical utility, and case studies focused on using genomics for patient selection for neoadjuvant chemotherapy in ER-positive breast cancer. During this 1-hour webinar, if you have any questions, you can submit them using the Q&A functionality at the top with the question mark icon. And at the end, if we have time, we'll address those questions. Before I hand it over, I will just give a brief introduction to our 2 presenters. Dr. William Audeh is the Chief Medical Officer at Agendia, and he's a medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in LA. Prior to joining Agendia, and in addition to his clinical practice, he served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. Dr. Audeh has been principal investigator on a wide variety of national and international clinical and translational trials and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. Dr. Jaime Alberty is a board-certified general surgeon with fellowship training in breast surgical oncology. He's the director of the Comprehensive Breast Center and director of the Division of Breast Surgery and Department of Surgery at Kings County Hospital. It's a 639-bed municipal hospital serving a highly diverse population in Brooklyn, where upwards of 94% of patients identify as Black, self-identify as Black, African American, or Afro-Caribbean. He is also the clinical assistant professor of surgery at SUNY Downstate Health Sciences Center, and his expertise includes all areas of benign and malignant breast disorders with a special focus on breast cancer. So with that, I'll hand it over to you, Dr. Audeh.
Thank you very much. I'm going to share my screen and bring up the presentation for today. All right. You should be able to see my introductory slide here, indicating our webinar series. This is the second, as you know, of a 3-part series, and I'm delighted to be joined today by Dr. Jaime Alberty from Kings County Hospital. Today, as you heard, we will be focusing on the use of genomics for patient selection for neoadjuvant chemotherapy, specifically in hormone-positive breast cancer. And to set the stage for today's discussion, I want to again review the gene expression profiling that's provided by the MammaPrint and BluePrint assays, which we will be discussing in their clinical context. MammaPrint, as you know, is a 70-gene gene expression assay that predicts the likelihood of distant recurrence of breast cancer, and is separated into identifying women at low risk or high risk of a distant metastatic recurrence, with a positive index for MammaPrint being low risk, negative being high risk. But as you can see, we further stratify both low risk and high risk into 2 additional categories each, ultra low and low risk on the low risk end, and then high 1 and high 2 on the higher risk end, something we'll be discussing in more detail as we discuss cases today. BluePrint, of course, is an 80-gene assay which analyzes a different aspect of breast cancer biology, the downstream signaling from surface receptors, if present, and will stratify tumors as either luminal type, being hormonally driven, HER2 type, or basal type, in which there really is no indication of growth emanating from a surface receptor. And in the case of hormone receptor positive breast cancer, using MammaPrint and BluePrint, we are actually able to identify 5 distinct genomically defined subtypes within hormone-positive, HER2-negative breast cancer, each of which has significant clinical implications, not only for prognosis, but also for therapy and therapy selection. So with that, I will turn things over to my colleague, Dr. Alberty, to describe our first case.
Thank you, Dr. Audeh, and thank you, Karen, for the introduction. You guys can hear me okay? Okay, so the point of today's webinar is we are looking at using both MammaPrint and BluePrint in our decision-making as surgeons so that we know which patients to refer out for preoperative systemic therapy. And so the first case that we're going to be highlighting is a case of a 60-year-old female, postmenopausal. She's originally from Suriname. She is of mixed ethnicity, both Caucasian and Black. And she presented to my office here in Brooklyn with a palpable mass 6 months prior to her presentation. She did have a breast that was a small C, large B cup breast. And this mass was originally worked up in her native Suriname, where, from what she obviously told me, she had had a fine needle aspiration that had yielded some malignant cells. She then came to the States, here to New York, and when she came here to my institution, we did diagnostic imaging. In the diagnostic imaging, both mammogram and ultrasound, we found 2 lesions in the same quadrant of her right breast. One of these lesions measured 2.9 centimeters, and then another lesion, which was more than a mass, it was just an area of, asymmetry or abnormality seen on ultrasound, and the radiologist recommended a biopsy of both areas. The larger mass yielded an invasive ductal carcinoma, whereas the smaller mass yielded DCIS. And thank you, Dr. Audeh. We can show the imaging. And so on the left, we can see the mammogram. And you can see both biopsy clips, and even though the biopsy clips are, I would estimate, like 3 centimeters apart, you can see that the whole area of asymmetry measures more like 4.5 centimeters on the mammogram. We did do a staging MRI, which, as you can see on the right side, the whole area within that quadrant of the breast measured 3.3 centimeters. And so this was sort of, within a smaller breast, an extensive area of disease, which sort of summarized 2 different distinct areas that were sampled, the whole area measuring 3 to 4 centimeters. And so, like I mentioned, there were 2 ipsilateral lesions in the right breast. One was an invasive ductal carcinoma. I should have mentioned there was no clinical evidence of abnormal lymphadenopathy, and so her clinical stage at this point would be a CT2-CN0. And like I mentioned, she was strongly ER positive at 95 and 80%, and HER2 was negative, and histologically it was a grade 2. She also had some DCIS, which was low grade, and it was associated with the invasive carcinoma within the same quadrant of the breast. So I guess as a surgeon here, when we're meeting these patients, the first question is, should we take them to surgery first, or should we consider some form of neoadjuvant therapy? When I was speaking to this patient, she was really interested, she was really motivated in breast conservation, and so I sort of grappled with her having a small breast, sort of a lot of cancer in one of the quadrants of the breast. And so, is that something that is worthy of breast conservation? And so, when we talk about the criteria to determine when to use neoadjuvant therapy, whether it's chemotherapy or endocrine therapy, as surgeons, we're looking, are we going to downstage a tumor, whether in the breast or in a patient that has a clinical adenopathy, metastatic adenopathy. And so outside of us trying to alter or modify our surgical approach, that's sort of what we've been used to when deciding whether to do neoadjuvant therapy or not. Now, we know that there are good responders, such as the triple negatives, the HER2 positive cancers, right? But in the ER positive, HER2 negative setting, it's harder to predict which cancers may respond or not. And so in this particular case, I was thinking, because she was so motivated for breast conserving surgery, then I was thinking, will there be a way for us to downstage both lesions in her breast so that we can do an oncologically safe surgery while obviously having a good cosmetic result? Other benefits, obviously nowadays we know that there's a huge benefit in understanding which patients achieve a pathologic complete response. And so that would be a third reason why us as surgeons would go after treating a patient preoperatively. And so, you know, in this scenario, we're sort of used to believing that strongly ERPR positive tumors don't necessarily respond that well to chemotherapy. So I did want to know what the genomics of the tumor was, and so we proceeded with a MammaPrint and BluePrint on the core biopsy. Doctor. And so this is the result that we got for this particular patient. Dr. Audeh, I lost your camera. I don't know if you're coming back.
I thought I was here.
I can't see you, but I don't know if other people could. So this is the result that I got. She was a MammaPrint high risk and BluePrint luminal B subtype. And again, this was in 2022, before Agendia was coming out with the differential between high 1 and high 2. But when you look at the index would be minus 0.590, which makes her a high 2. So she would be a luminal B MammaPrint high risk 2 tumor, which, yes, as we know, oh, you can.
I'm sorry. Can you hear me?
Yes, I can.
Okay. Yeah, I wanted to jump in and kind of add to that point, Dr. Alberty, that as you mentioned, we previously had not really recognized the distinction between high 1 and high 2 within the MammaPrint index. And as you can see there, what we predicted based upon simply being luminal B and MammaPrint high was a probability of pathologic complete response of 6%. That was in the report. And in addition, there is this bar graph that compares the different subtypes identified by MammaPrint and BluePrint with the predicted PCR. And I wanted to point out that that number of 6% was derived originally from the NBreast neoadjuvant trial, a study from which there have been several publications. This was a neoadjuvant trial conducted about a decade ago with 1,100 patients approximately enrolled. Each of these patients had a core biopsy on which the immunohistochemistry had been performed, but we also performed MammaPrint and BluePrint on that same sample. And then we looked at the likelihood of pathologic complete response as predicted either by the immunohistochemistry or the genomic analysis. And you may remember from a previous presentation, this Sankey diagram, which showed in the upper bar there, the hormone receptor positive HER2 negative patients identified by IHC, who were then further stratified by MammaPrint and BluePrint into luminal A, luminal B, and basal type. Interestingly, the luminal B type overall had a PCR rate of 6%, as compared to only 2% for luminal A, and of course 34% for basal. But the important thing is that within luminal B, there are both high 1 and high 2 cancers. And so recently, specifically last year's ASCO, we went back to the NBreast cohort and further analyzed the PCR results based upon high 1 versus high 2. And those data are shown here in a spotlight poster that was presented by Dr. Peter Beitsch at ASCO, where you can see that when we further separate MammaPrint high risk into high 1 and high 2, that the rate of pathologic complete response is actually quite different. As the MammaPrint index becomes more negative or into the higher risk range, you can see that the likelihood of a pathologic complete response to neoadjuvant chemotherapy goes up significantly now from 6.1% to 23.3%. We confirmed these results by looking at our FLEX study, which is a real-world database now containing over 16,000 patients, where we also analyzed the rate of pathologic complete response in patients with MammaPrint high 1 versus high 2, and we had very similar results here. These data, which were presented by Dr. Joyce O'Shaughnessy at the most recent San Antonio meeting in December of last year, added beyond just MammaPrint high 1 and high 2, the BluePrint classification, which allows for even more precision in predicting the likelihood of a pathologic complete response. So you can see here, luminal B high 1, 5.8%, high 2 up to nearly 22%, and then you can see high 2 basal, a significant increase in the likelihood of PCR. And this, of course, is in comparison to what we already know about the very low likelihood of PCR with luminal A tumors. So really adding significant granularity to the prediction of PCR in hormone-positive breast cancer patients with this increasing likelihood of PCR based upon the genomic definition. So here we have identified 2 subtypes of hormone-positive breast cancer, one of which applies to your patient, Dr. Alberty, high 2 luminal B or a BluePrint basal, both of which have a significant likelihood of PCR. One further question which we are exploring and for which we have actually presented some data is whether the likelihood of PCR within these categories is affected by which chemotherapy regimen is used. And not surprisingly, the majority of regimens that were used in these patients were either TC or ACT in the neoadjuvant setting. And so these are data that were just presented actually at the Miami Breast Cancer Conference very recently that I had the pleasure of being first author for. And here, what you see is separating the likelihood of PCR based upon what type of regimen they received. So for high 1, you can see that there is very little difference in the outcome between those receiving TC versus an anthracycline-containing regimen. But when we further stratify to high 2, there's quite a striking difference in favor of the anthracycline-containing ACT in terms of the likelihood of a PCR. Again, adding BluePrint to that high 2 group, we do further stratify the high 2 group into luminal B and a high 2 basal, but again, really much more significant responsiveness to the anthracycline-containing regimen, which really, I think, confirms that MammaPrint high 2, whether luminal or basal, does identify a highly chemosensitive subpopulation, where anthracycline can be safely withheld, I could say, from high 1 patients, but may be a strong consideration for high 2. Now, this is neoadjuvant data, and of course, the real test is the outcome, and we will actually be presenting adjuvant outcomes in these cohorts of TC versus ACT for luminal B patients coming up at the next ASCO meeting, so stay tuned. So back to your case, Dr. Alberty. You can walk through how you managed her based upon that information.
Yeah, so again, this was back in 2022. I did not have this new PCR data. And honestly, I wasn't going after PCR. I was just going after trying to downstage and make her a conservation candidate. And so we considered doing neoadjuvant chemotherapy. We did do a genetic panel, which yielded no pathogenic mutations. And so she was referred to medical oncology, who agreed to proceed with neoadjuvant chemotherapy in the form of dose-dense ACT. She did very well throughout her chemotherapy regimen. And once she finalized that regimen, we re-imaged her. And, you know, in a very encouraging way, we saw that the MRI had no enhancement after therapy. Whereas before treatment, she had that big mass measuring 3 centimeters. And so we decided to go ahead and attempt the lumpectomy, the localization. Again, at this point, she still had the 2 foci that were biopsied within the same quadrant. So we proceeded with a bracketed lumpectomy in the sentinel node. And you can see here on the right side a specimen imaging of the area that was excised, including both localizing wires and both localizing biopsy clips.
And so I'm assuming that you were able to encompass the area that had been previously biopsied as invasive ductal cancer as well as the DCIS region?
Correct. So both areas that were biopsied and marked by biopsy clips previously were localized with the use of these wires. And so both specimens came out within one larger specimen.
So here's the pathology, if you can walk us through the results.
Yeah, so she, like I mentioned, she had a sentinel node biopsy. We excised 3 specimens, ended up having 7 lymph nodes that were all negative. And to our surprise, the lumpectomy in the breast yielded no residual invasive carcinoma. There was some ductal carcinoma in situ of grade 2, and all the margins were negative for both for invasive cancer because there was no residual, and then for DCIS. There was biopsy site changes, which is obviously something we always look for to confirm that we excised what we had biopsied previously. And so in this case, we achieved a path CR.
Wonderful outcome for her. And again, not surprising given that what we know now is with a luminal B high 2, that the likelihood of a PCR is quite significant. So can you tell us the subsequent therapy that she received?
Yeah, so she proceeded after surgery. She proceeded to get radiation therapy to her whole breast. She went back to the medical oncologist, and they spoke about endocrine therapy in the form of an aromatase inhibitor for 5 years.
I've added this because if you recall our last case discussion where we looked at the aspect of endocrine management based upon MammaPrint and the data soon to be published from NSABP B42 and the IDEAL trial, both showing that MammaPrint identifies women who may benefit from extended endocrine therapy. And those are the low-risk women who are not ultra-low, with really no benefit for extended endocrine therapy, and MammaPrint high-risk women such as your patient here. So while certainly 5 years of aromatase inhibitor would be absolutely indicated, there doesn't appear to be evidence that she would benefit from any more than 5 years. I wanted to ask, was she considered for a CDK4/6 inhibitor?
So I know that the medical oncologist discussed it with the patient and documented in the note, but ultimately decided that she was not a good candidate for it, and so they did not proceed with that treatment for her.
Interesting. I mean, I don't think that she met the clinical criteria that are now used for indicating abemaciclib, although, as I think many people know, the recently reported NATALY trial with ribociclib used more liberal clinical parameters to enroll patients, including those that were T2 and 0, as your patient would be. So based upon NATALY, she may have been appropriate, but we're still waiting on the decision regarding ribociclib. So let's move on to the second case, Dr. Alberty, if you can walk us through the presenting data.
Yeah. So this second case is an interesting case. It's a case of a 46-year-old Black female. She's originally from Guyana, living in the States now and here in New York. A healthy woman, G0, P0. She's premenopausal and regular periods. She did have family history of breast cancer in her sister at the age of 45, and this patient was treated back in Guyana. There was no genetic testing, and we didn't really have any further information as to her diagnosis. So this patient presented with a mass with associated nipple retraction since 10 months prior. She originally noticed the nipple retraction, thought nothing of it, and then felt a mass in her breast. Obviously, 10 months is a long time, and so she took some time to get medical care. But when she presented to my office, she was presenting with a mass measuring at least 4 to 4.5 centimeters with some nipple retraction. as was described by her. There was no axillary adenopathy on exam. And so obviously we proceeded with diagnostic imaging. And on diagnostic imaging, we saw a mass measuring 4.5 centimeters in the right breast with associated retraction of the nipple seen on mammogram. We can see here the images on the right side, the CC and the MLO views on the mammogram, and you can definitely see an asymmetry in the breast with some pulling of the nipple or retraction of the nipple seen on the mammogram. And on the right side, you can see the ultrasound images of the mass, which in this view, the largest dimension was 4.5 centimeters.
And so you proceeded to a biopsy?
We proceeded to an image-guided biopsy, and that biopsy yielded an invasive lobular carcinoma of grade 2, strongly ER positive at 95%, PR at 55%, HER2/neu was negative at 0, and Ki-67 was performed also, which yielded 30%. So again, in this particular case, this is sort of a larger invasive lobular breast cancer. The staging in her case would be a T2 and 0. And she, like I mentioned, she was strongly ER positive, PR positive, with a Ki-67 of 30%.
Yes, I think based upon imaging, at least that ultrasound measurement of under 5 centimeters, she may be clinical stage T2 as written here. One could argue perhaps, though, from palpation and physical exam that she may actually be clinical T3. So because of her family history, you did genetic panel testing.
Yeah, family history and the fact that she was a woman under 50 years old. And again, to our surprise, she came back with a pathogenic mutation in the CDH1 gene, which, as we know, has a link to lobular carcinomas.
So your management here?
Yeah, so obviously we spoke about treating her ipsilateral, the breast with tumor, but we also spoke about a contralateral prophylactic mastectomy in the setting of a genetic mutation. As per NCCN, the absolute risk of breast cancer in a CDH1 mutation carrier is 41 to 60%. And so in those cases, NCCN does recommend discussion for risk-reducing mastectomy on the contralateral side. I guess in her, not to interrupt you, Dr. Audeh, but in her case, like you were mentioning, yes, the imaging was like slightly under 5 centimeters, but the mass definitely felt larger than that. And so it felt like we knew what we had to do surgically.
So in discussing the risk of a second primary breast cancer in the contralateral breast that raised the question of prophylactic mastectomy, I think it's interesting to just speculate on the role of CDH1. It's obviously ECadherin, which is diagnostic of lobular breast cancer in its absence. And I think very interestingly that there's been recent data for patients who have either germline or somatic mutations in CDH1 that has led to an invasive lobular breast cancer. But most recently, even when there isn't a mutation, either germline or somatic, in the CDH1 gene itself, there appear to be other associated mutations or even methylation changes, epigenetic changes, which lead to the same phenotype, which is the loss of ECadherin expression and a lobular breast cancer. So there's actually quite a bit of diversity biologically within this category of lobular breast cancer. So in discussing the potential for prophylactic mastectomy, your options obviously were to go straight to surgery or to begin with some form of neoadjuvant therapy.
Yes, and like we mentioned in the earlier case, when do we consider neoadjuvant therapy? When we want to alter our surgical plan, or when we want to consider a pathologic complete response or the goal of a pathologic complete response. And so in this case, we spoke to her about a mastectomy on the cancer side. We spoke to her about a contralateral prophylactic mastectomy. And so our surgical plan really would not have changed. She had no desire for downstaging or for attempting breast-conserving surgery. And so in this particular case, we sort of knew what surgically needed to be done.
But you had genomic information at this point prior to your surgery, I believe.
We did.
So,
like we mentioned in the webinar earlier, I perform MammaPrint BluePrint assays on patients when they present on core biopsy, and so we did have this information. You can see here the report. This core biopsy yielded a MammaPrint high risk luminal B. Again, this was in 2022 before high 1 or high 2, but if we look at the index now, she would have been a high 1 tumor.
Yes, with that probability of PCR more accurately reporting what you would expect with neoadjuvant chemotherapy in a luminal B high 1 patient. So biluminal from Blueprint confirming that there is intact hormonal signaling downstream from the estrogen receptor, but also on the lower end of the high risk index being high 1. So to remind everyone here of the distinction that we make between high 1 and high 2 at the point of minus 0.569 as the upper limit of high 1 and high 2 beginning at minus 0.570. Your patient, Dr. Alberty, was at the very low end of high 1, as a matter of fact. So she is a high risk 1 luminal type B. So here's the pathology from your bilateral prophylactic mastectomy. Can you walk us through the results, please?
Yeah, so we performed a bilateral total mastectomy. On the right side, we had a sentinel node biopsy. We did perform frozen section because a lymph node that was excised felt a little abnormal, and that surprisingly came back with metastatic deposit. So we proceeded with a completion dissection. And so in sum, she had 10 centimeters of invasive lobular carcinoma in the right breast. 1 out of 12 lymph nodes ultimately were positive. The contralateral breast was completely negative. And so her staging pathologically was a PT3 PN1A.
So I wanted to digress for a moment because there are often questions raised to me about the experience with MammaPrint in invasive lobular breast cancer. Of course, the majority of data that's been generated with genomic assays in breast cancer have been in invasive ductal carcinoma. And so the largest cohort that we have is actually from the MIND-ACT trial. These are data that were presented at San Antonio a few years ago and are now actually with more analysis and longer follow-up in press and soon to be published. But I wanted to point out that there were nearly 500 patients with invasive lobular cancer enrolled in the MIND-ACT study. And what I want to actually focus on are those that were found to be MammaPrint high risk, comparing lobular to ductal. Within the high risk category, 39% of the invasive ductal cancers were high risk. Only 16% of the lobular cancers were high risk. But of those, as you can see, the outcomes in terms of distant metastasis-free survival, DMFS, or disease-free survival, DFS, were very similar to what was seen in invasive ductal carcinoma. In other words, high-risk lobular identified genomically behaves very similar to high-risk ductal. And I think the notion, the prevailing belief perhaps, that lobular cancers tend to be more indolent and less aggressive may be true for the majority, but genomically, we can identify those that are actually more aggressive and need more aggressive therapy than is typical for lobular cancer. And I'll also point out that apart from the large size, the molecular profile of your patients tumor, Dr. Alberti, in terms of the ER/PR, weren't particularly high risk apart from perhaps the Ki-67.
Correct. I agree with that.
So can you tell us about her post-operative management?
Yeah, so based on both the size of the tumor that was excised in the breast and the fact that she had positive metastatic adenopathy, she was referred to radiation oncology, and they agreed to proceed with post-mastectomy radiation therapy. She also saw medical oncology, and in terms of adjuvant therapy, based on what was found in surgery and also the genomics of the tumor on the core biopsy, they decided to proceed with a recommendation for adjuvant chemotherapy. In her case, she was recommended for TC, and after she finished that, the recommendation was to proceed with endocrine therapy in the form of an AI with OFS. In her particular case, she was also recommended for a CDK4/6 inhibitor due to her higher risk.
Yeah. So just to pause for a moment here. So this young woman with a large breast cancer has gone through extensive surgery with bilateral prophylactic mastectomy, adjuvant chemotherapy, adjuvant endocrine therapy, as well as CDK4/6 inhibitor therapy, and post-mastectomy radiation therapy. A lot of treatment to seek a cure for her breast cancer. But as we know, carriers of CDH1 germline mutations are also at risk for gastric cancer. Was there any gastric cancer in her family history, Dr. Alberti?
There was no gastric cancer in her family history. There was only that one sister with breast cancer, not gastric cancer.
And the data that we have regarding the management of CDH1 germline carriers is that those women who do have or individuals who do have a family history of gastric cancer clearly have a higher risk of themselves developing it. But even those who do not have a gastric cancer family history, they still have a significant risk. So is there any utility to screening, or is this again another case for prophylactic gastrectomy?
Yeah, so obviously, I'm a breast surgeon and I'm not a surgical oncologist, but she was referred to surgical oncology, and that was discussed, and I believe they are planning on proceeding with a total gastrectomy. If you look at the NCCN guidelines, it is quoted as high as 83% of females who are mutation carriers may develop gastric cancer at some point in their life. And so the official recommendation is a prophylactic gastrectomy between the ages of 18 and 40 for CDH1 mutation carriers. And obviously, this patient is a little older than that. So in terms of recommendations, she would be definitely recommended for it. The total gastrectomy would be without a D2 lymph node dissection. And so in the setting of a patient not wanting that, which would be sort of against the big recommendation, she could definitely get screening. And I believe that screening entails random biopsies of the gastric mucosa.
Well, in view of the extensive treatment that she underwent to achieve cure of her breast cancer, it would seem logical that she may want to continue to protect herself with prophylactic gastrectomy, although that's clearly a major surgery. You mentioned that in such an operation, you don't typically sample D2 nodes, but what happens when you find, at the time of careful pathology evaluation, some evidence of early gastric cancer that wasn't really appreciated clinically? Does that require repeat surgery?
Like I said, Dr. Audeh, I'm not a surgical oncologist, so I haven't done that surgery in years. But I would gander a guess that if there would be occult disease, then that would definitely require additional excision of lymph nodes, followed by adjuvant treatment as well. Yeah,
thank you. Well, let me kind of take a higher level look at what we've been discussing here. I've presented data and we've discussed data both last week and this week, and regarding the ability of MammaPrint risk and blueprint subtype together to predict the likelihood of PCR with significant granularity and precision. And it is certainly relevant to the criteria that are used to select patients with hormone-positive breast cancer to be considered for neoadjuvant chemotherapy. In this case, and the cases we've discussed, clearly large tumors presenting with large primaries and clinically positive nodes could be candidates for neoadjuvant chemotherapy if there's the expectation of response and there's the desire to convert a modified radical mastectomy to breast-conserving surgery. Of course, from what we've seen with MammaPrint and BluePrint, if such a tumor were luminal A, for example, it would be a very low likelihood that neoadjuvant chemotherapy would provide any benefit in terms of significant downstaging. I think the unique aspect, however, is for smaller high-risk ER-positive breast cancers, as to whether a PCR may be attainable, and the likelihood then of, with positive nodes, potentially targeted axillary dissection, and then learning the prognosis based upon the responsiveness to neoadjuvant chemotherapy, something that we've seen, for example, with the ER-positive basal breast cancers, which behave very much like triple-negative breast cancers and have a very poor prognosis if, in response to neoadjuvant chemotherapy, they do not achieve a PCR. So this issue of the chemosensitivity of a hormone-positive breast cancer is very relevant to predicting the likelihood of PCR. I'll remind you of the data I showed earlier, which is that particularly with MammaPrint high 2, both luminal B and basal, we're identifying hormone-positive breast cancers that have a prediction of PCR significantly higher than what's usually seen with the majority of hormone-positive breast cancer patients. And this high 1, high 2 distinction actually derived from the application of MammaPrint to the I-SPY trial, which many of you know well. This is a neoadjuvant study which from the outset used MammaPrint high risk as an enrollment requirement for hormone-positive patients. And over the years, with many patients enrolled, the I-SPY investigators observed that the likelihood of achieving a pathologic complete response, even to the standard of care arm of ACT, nearly doubled when one went from the lower end of high-risk MammaPrint to the higher end, here referred to as MammaPrint high 1 or high 2, with the threshold between these two being at the minus 0.57 level. Now, this high 2 group being identified as having double the PCR rate is, of course, very relevant when considering whether or not a PCR can be achieved in a hormone-positive patient. But another question that I've also been asked, and you also may have encountered this in your tumor board, Dr. Alberty, is whether PCR actually matters in hormone-positive HER2-negative breast cancer. We know from large meta-analyses of neoadjuvant therapy, such as the Cortazar study, for example, that even those hormone-positive patients who don't achieve a PCR still do relatively well for the most part. So why do we care, in other words, if a PCR is achievable? And in fact, it was again the I-SPY investigators who addressed this question, I think, in a very relevant manner. Here are I-SPY data that were published by Dr. Yi and his colleagues in JAMA Oncology a few years ago, looking at the 3-year event-free survival in all of the patients enrolled in the I-SPY trial, stratified by whether they achieved a PCR in the dark blue line versus no PCR in the orange line. Now, this included all comers, of course, all subtypes. So when they further stratified by IHC and FISH subtyping, they reported these graphs, which are quite busy, but I'm going to walk you through them. those that achieved a PCR on the left, a no PCR on the right. And again, we're looking at event-free survival at 3 years. So when we focus just on hormone positive, HER2 negative on the left and on the right, you can see that actually the event-free survival is quite different depending on whether a PCR was achieved. 96% with a PCR versus 81% without a PCR. Now, this is quite different from the large unselected neoadjuvant data that has been reported thus far. And the distinction here is that these are all MammaPrint high-risk patients. The event-free survival is not diluted by MammaPrint low-risk patients who are likely to do well with or without chemotherapy. And that's the point. PCR does indeed matter for hormone-positive patients if you identify them as high genomic risk, particularly HER2, and of course, particularly basal. So what does the NCCN say about selecting patients for neoadjuvant chemotherapy? Well, here are some recent NCCN guidelines indicating candidates for postoperative, for preoperative systemic therapy. And I call your attention to this line here, which indicates that preoperative systemic therapy can be considered for clinical stage T1C and 0 when you're talking about HER2 positive or triple negative disease. And that is primarily because of the observed high likelihood of PCR and chemosensitivity for those subtypes. But what about estrogen positive breast cancers? Well, they go on to also state that preoperative systemic therapy may be indicated if the patient's breast cancer subtype, not otherwise specified, is one that's associated with a high likelihood of response. And we've now established with MammaPrint and BluePrint that MammaPrint HER2 luminal B and ER positive basal do indeed have a high likelihood of response and PCR, making them good candidates for consideration of neoadjuvant chemotherapy. Now, based upon what NCCN has said regarding HER2 positive and triple negative breast cancer, I think we can now add to the two groups that are typically considered for neoadjuvant chemotherapy. Within hormone positive patients, we find two additional categories, as I've just mentioned, luminal B HER2 and ER positive basal. Now, since these have such a high likelihood of PCR and subsequent nodal downstaging, it's reasonable to ask, well, what is the clinical stage if you know that you have a luminal B HER2 or ER basal to consider neoadjuvant chemotherapy? Of course, this is only possible because of the rapid turnaround time from the point at which we receive a genomic sample to the point at which it can be reported back, which is in general around 5 to 7 days from the point that we receive the tissue, certainly rapidly enough to be available prior to any systemic or surgical decisions. Has that been your experience, Dr. Alberty?
Definitely been my experience. And like I mentioned, we order it always on the core biopsy. And so usually I have this information by the time I meet the patient.
So in terms of rethinking the selection of hormone positive patients for neoadjuvant chemotherapy, when you have a preoperative gene expression profile, it's reasonable to call the comparison between, for example, ER positive basal and triple negative breast cancer, where the guidelines suggest T1C or T2N0 is an appropriate clinical stage. We now, of course, know that ER positive basals have a very similar PCR rate to triple negative breast cancers, and luminal B HER2 has a somewhat lower PCR rate, but still well above 20%. So it's reasonable now to consider reassessing our clinical criteria for when neoadjuvant chemotherapy should even be considered for hormone positive patients and not limit that decision to only those that are clinically advanced large tumors where some type of anatomical downstaging is desired. Here, what one could argue that T1C or T2N0 is appropriate when one knows that you have an ER positive basal or a HER2 luminal, good candidates for neoadjuvant chemotherapy. Now, Dr. Alberty, you had shared with me earlier regarding these two cases that they were both enrolled in the FLEX study and that many of your patients are enrolled in that trial. And I wanted to simply define it because this will be the topic of our third and final webinar, which is to talk about the clinical research that's advancing progress in breast cancer. The FLEX study, which is sponsored by Agendia, is MammaPrint BluePrint and full genome data linked with clinical data to evaluate new gene expression profiles, a so-called adaptable registry. And the acronym FLEX comes from this title. The design of the FLEX trial I'll show here. Nearly all patients with newly diagnosed non-metastatic breast cancer can be enrolled with IRB approval and patient consent if they undergo standard of care MammaPrint and BluePrint testing, just as Dr. Alberty's two patients did. But what we do when we perform the MammaPrint and BluePrint analysis is that we also capture whole transcriptome data on that tumor. And both of these tumor samples that Dr. Alberty submitted for MammaPrint and BluePrint are now in the FLEX database with whole transcriptome data that we can go back and analyze in more detail, annotated with a significant number of clinical data elements. This large database now exceeds over 16,000 women enrolled in this manner and has yielded multiple additional sub-studies that, as we refer to them, looking at a variety of aspects, including neoadjuvant response, as I showed you from Dr. O'Shaughnessy's abstract presented at San Antonio, but also adjuvant results, and of course, studies we've done looking at the role of genetic ancestry. What full transcriptome data allows, among other things, is differential gene expression comparisons, but also pathway analysis to allow us to develop new signatures, one of which I will talk about in more detail on our next webinar.